morning, everyone, and welcome to today's regional COVID-19 virtual open forum. I'm Nancy Miller with Stratus Health in Minnesota, which is a partner in the Superior Health Quality Alliance, or Superior Health. Just as a reminder, the purpose of today's call is to provide a menu for networking and sharing about COVID-19 concerns across settings in healthcare. Our next slide shows a little bit about Superior Health Quality Alliance. Could you forward to the next slide?
Are you seeing my slides advance?
No, I'm not seeing them advance.
I must be having some technical difficulty with that right now. I'll pop out and pop back into the slides. Give me 1 second if you want to go over the welcome messages.
Sure. I just wanted to mention that Superior Health Quality Alliance was formed in 2018 with 8 healthcare organizations across 6 states. And you'll see a map of that when she is able to bring that up. The Superior Health works to achieve broad national CMS quality strategic aims with the goal of collaborating to improve the quality of health and healthcare for consumers, patients, clinicians, organizations, and the communities we serve. Just some reminders that all of these sessions are being recorded. So if you or any of your colleagues want to go back and look at them, you can certainly do that. If you have any problems with Zoom, please message Alina Smith using the chat box, and she'll help you out. We want to remind you to mute yourself when you're not speaking, and then if you do want to talk, then unmute yourself and state your name when you're participating. And we again want to remind you to please don't disclose any personal health information during our discussions. If you do have any questions or comments, which we encourage, of course, please chat them to everyone so that a member of our team can address your questions for everybody else. And please help us foster a positive learning environment with asking questions or making comments, because we're all here to learn from each other. We begin today's call with a brief presentation on responding to COVID-19 by Diane Carlson, who is the Executive Director of the Midwest Kidney Network. Diane has 37 years of experience with nonprofit healthcare agencies working to improve the quality of healthcare, and 34 of those years have been working with the Endstage Renal Disease Network program. She is a registered health information administrator with experience in organizational and contract management, quality improvement activities, and health information administration. So with that, I will turn it over to Diane.
Thank you, Elena, for teeing up our slides. This will be a fun opportunity. I'll be speaking for about 10 minutes. Thank you for joining. With all of the competing ways for your time, I did want to talk a little bit about end-stage renal disease. I'm just looking, thanks to Elena for doing a quick a check of attendees, that we have a variety of people from hospital, looks like nursing home, and home health. So thank you for that audience, and I will presume that people don't have a lot of experience with detailed kidney disease, so I'd love to teach us a little bit more about ourselves and what we have been doing for these last 2 intensive months, trying to respond to the COVID crisis and help what we can with patients. So if you want to go to the next slide, I'll walk a little bit through the agenda for this next 10 minutes. 1, I'd like to introduce Midwest Kidney Network, what we do and how we might work with you in the future. 2, we are able to achieve what we do because we have wonderful partners, and those stakeholders became particularly important during the COVID era. 3, one of our main goals during this short 2-month period is to collect and share information. I'll talk a little bit about that. I also want to share with you the issues that we faced and the activities that we did and resources that provided to respond to those concerns. And 5, talking a little bit about the concerns that we hear from patients and providers. Next slide, please. To introduce Midwest Kidney Network, I'd like to say that our mission is to assess and improve care for patients with kidney disease. Now, there's three main buckets of kidney disease that I'd like to describe. Is that the first are in real early stages and they don't need kidney transplant or dialysis to survive. The second group is end-stage renal disease, and to survive, they would need regular dialysis or kidney transplant. And the third group you might meet is acute kidney injury patients, and they are not chronic patients, but they might have situations in their lives where they may need some dialysis. So our organization was created and we have three main functions. Number one, we do quality improvement. Number two, we respond to patient and facility concerns. We're the appellate body for grievances. And number three, we are do registry management for people who have kidney disease, and we track them throughout their life through their different modalities. When you say quality improvement, that's not very specific because all of you are doing quality improvement. But specifically, I'll just offer a couple of examples. We are working really hard to promote more and more people having access and getting kidney transplants, more and more people going to dialyze at home. Those modalities are associated with the best patient outcomes. We also try to decrease infections, specifically bloodstream infections, and we try to work with particularly those of you in hospitals when patients come in and are diagnosed with end-stage renal disease. We want to, they sometimes have to start with a catheter to have a vascular exercise for dialysis, but we want to get that long-term catheter out to not create infections later on, so we'd love to work with you on that. Number two, the grievances that we process, we probably do about 500 a year. And patient registry management, we serve about 50,000 patients. So next slide, please. We serve a 5-state region, and it's a little bit different than Superior Health in that we include North and South Dakota, Minnesota, Wisconsin, Michigan. And you can see on the slide here that we work with about 535 people who provide the care, dialysis and kidney transplant centers, and we serve about 50,000 patients. Next slide, please. The dialysis patients that we serve are served by 4 main provider types. 3/4 of them are for-profit dialysis providers, and those are DaVita and Fresenius Medical Care. And for those of you who are discharge planners and who see end-stage renal disease patients come in, you're working to place them back in their home units. But also we do have another 4 that are independent and regional chains. So thank you for that. And next slide, please. So when COVID hit, we have a contract with Centers for Medicare and Medicaid, and they gave us a contract modification, and we all had to hit the ground running. So in the last 2 months, we were assigned the job to kind of be the vital statistics department for counting people who did have COVID for dialysis patients and those that might be patients or staff that are persons under investigation. So we managed that registry, and that helped us to define where supplies were needed, services were needed, and helped to inform the country. Secondly, we were to, once we all saw that CDC resources, for example, changed infrequently, everything from telehealth to guidelines on infection control, and it was our job to get those resources out to people and answer their questions. If we couldn't, then we tried to call those official resources and get that back with them. Third, we were supposed to educate people, patients and staff. And we were, number 4, supposed to assist facilities with emergency plans. They too were the whole country ended up having some unexpected and unscheduled work. And 5, we do provide 24/7 coverage of our phone lines for patients and providers calling with questions. And 6, we do work with a national group that has that we've been doing emergency preparedness for probably, I don't know, at least over a decade. And that group is called the Kidney Community Emergency and Response, CASER for short. And they have been meeting daily since COVID. Next slide, please. We can't do this work without our partners, and our main circle, as you are all doing patient and family engagement also, we work directly with people who have the disease. We have a 15-person consumer committee. They represent all modalities, and when in doubt, and if we want health literacy and our education to match, they are our touch point and people in the dialysis unit to make sure that our education materials match. Of course, we work with dialysis and kidney transplant providers. They are the frontline people giving the care. We work with skilled nursing facilities. For some of you, you may have nursing home residents and skilled nursing residents that need dialysis. Some of you are transporting those patients to the dialysis unit or in critical condition to the hospital. We're working with you and others to help those transitions go smoothly. For those of you who are hosting dialysis in your unit, we've been working to help to make sure that your provider has the supplies that they need. We've also been intensively working with local and state health departments. We work with the state survey and certification. We work with emergency preparedness departments. We also work with the Kidney Foundation affiliates that cover this, the National Kidney Foundation affiliates that cover our 5-state region. Next slide, please. This is a busy slide, but I'd like to just call your attention to the far right 2 columns. You will see, for example, state-specific rates that dialysis patients have COVID positive results. So in Michigan, in that first line, you can see that dialysis patients had 34 per 1,000 people versus compared to the general population in Michigan was 3. So looking at the very bottom of that, that averaged out with basically a 12-to-3 ratio that we know, and this proves, and this is just people that we knew confirmed and had a positive test. So we've been saying all along that dialysis and transplant recipients, this is just dialysis patient data. So we know that they're a vulnerable population. So thank you for the good care that you provide to them as as they come to your hospital and as they're in your nursing home. Next slide, please. This slide really showcases the disparity there, that these are the blue lines are the dialysis population, and the orange bars are the general population. So I think if there's one takeaway from this talk, you will see how vulnerable a population, and that they were really extraordinarily more affected than the average population. And we're also seeing that it's also particularly true for African American population and so other socio determinants of care. Next slide, please. This one's a really quick summary, and I won't go into all of the details because it's been an intensive couple of months, but on the left side, you'll see whatever some of the issues we say, issues we faced, and on the right side are some of the things that we tried to do to mitigate those issues. So in the first row, you'll see we were seeing all sorts of last-minute executive orders, regulatory guidance, CDC guideline changes. We have an email list with probably about 2,000, 3,000 people. We do e-news to that list, and we have a website. We try to help people. The next row is about personal protective equipment. We saw the whole nation was struggling with that. Well, we saw each of our 5 states did not peak at the same time. So sometimes organizations would take dialysis supplies and personal protective equipment from one unit and share with another. We also admirably saw people that were former competitors shared supplies with one another. The third row talks a little bit about transportation, and we really did not want, in that transportation exchange, we did not want to expose patients to COVID unnecessarily. So if people were transporting people from a long-term care facility to a dialysis unit, we wanted to make sure that they were tested before transportation, so you weren't transporting symptomatic patients with asymptomatic patients in the same van. We did produce transportation tips. They were just a one-page thing. They were specific to transportation in Michigan, in Minnesota, and in Wisconsin. We're in the process of working with the Dakotas on the same thing. The next row is talking a little bit about dialysis settings. So people might wonder, well, if you were a dialysis patient and you did get COVID, what happens to you? They still need dialysis. And so the dialysis industry quickly got a system to screen and cohort. And what I mean by cohort is that patients then, if they stayed in their home dialysis unit, they were probably then on a Tuesday, Thursday, Saturday late shift that was deeply clean between the non-COVID patients. Some of the organizations had enough patients that they quickly evacuated some of their smaller dialysis units and saved that physical space for a COVID positive unit. So every patient dialyzing there was COVID positive. The next row is a little bit about staffing shortage. Dialysis nurses also got it. PCT, patient care technicians also got COVID. So we were sharing staff from dialysis unit to dialysis unit. We were also seeing very generous and intensive education that hospital staff were redeployed, and they might not have formally been trained in dialysis, but they helped with screening, medication distribution, and other things. The last row, and a very important role, and I'm sure you're seeing it in your places too, we're all struggling with mental health for our patients and in our staff, trying to help with the stress of that and offering resilience and ways to mitigate that. Next slide, please. This is a real quick summary of what I've been trying to explain, that in the last maybe 6 weeks or so, we've responded to 40 individual, and usually they are more complex. If it was easy, the facility and the patient would have solved it on their own. So we try to use our multi-facility, multi-state resources to respond to those 40 concerns. We also engaged in about 120 specific activities where we hosted facilitating calls where people would say, I don't have enough supplies, you do. We did those in Michigan, we did those in Minnesota, Wisconsin. We did them every week, and they were multi-organizational sharing and what procedure are you going to be using, the test or the non-test, to identify? How do you determine who's recovered, and then how fast do you to turn them? It was a very dynamic exchange, and that was very popular. We do have a Facebook site, and that's how we do a lot of our patient education. And we also have a tweet account. That's where we do more of our provider education. On our website, it's nicely navigated so you can see patient and provider education. And at the end of this talk, you'll see the COVID resources. The next one, we then post those resources to our website. We hope it's easy to navigate so that people can find their answers to their question. And as I mentioned earlier, we try to respond to people's questions. And if we can't, we will go to the source and get back with them. Hopefully, our goal is within 24 to 48 hours. Next slide, please. I guess more than anything in this talk, my two takeaways is that, yes, dialysis and transplant patients are particularly vulnerable, so thanks for listening to that. My second most important relay is thank you for all you are doing to help to improve healthcare. This is a really trying time. Everyone's stressed, and I thank you for all the work that you're doing too. So if you have more questions, please go to our website, and you can go and send our questions to this email address, but Elena has also offered to help, that if you have questions, you can go through the Superior Health channels. They'll get them to us, and we'll try to respond to your question. Thank you so very much for this opportunity to talk to you and share about something we're passionate about.
Well, thank you so much, Diane, for your talk today. I think we all learned something, and if nothing else, we're all in this together, but we all appreciate everything you're doing to keep your patients safe. Okay, I have a couple questions in the chat. First, Nikki said, great presentation, thank you. Lisa asked, do you test more dialysis patients than the regular population?
That is it's a really good question. You are on the ball. Right in the peak of COVID, there weren't enough tests, so we were doing it. Most dialysis providers were doing it on symptoms, signs and symptoms, temperature, some of the traditional. That is being expanded, and tests are more and more. And just yesterday, there was a national call. Would we start testing regularly? Would they be somewhat like nursing home population that we're going to start testing them? That remains to be seen, but at this point in time, the primary thing for the 50,000 patients that we serve, it's based on symptomatic. So I believe that the test results that you saw and the numbers that you saw are probably underreported.
That's good information. Are there any other questions from those on the call? You can also put you just unmute yourself and we'll call on you. You can also put your question in chat or any comments that you have, and we will make sure Diane gets those.
Diane, a question. That was a wonderful presentation. I really appreciate it. I'm Barb Link from Superior Health. I was just wondering, and I know it's very early, but do people with kidney disease, has anyone noticed if they present any differently, their symptoms any different with COVID, or any sort of things that present themselves first that are different than the general population or anything like that?
Let's kind of take three different populations. I would say our nursing home population, we're hoping to, particularly if they're going to get transported, the main things that they're looking for is signs and symptoms, and they are similar to the general population with being any kind of fever, any kind of shortness of breath. I think we're also expanding that now that we're seeing community transmission. So we're watching for diarrhea, vomiting, new kinds of cough. So that was the first part of your question. The second part was signs and symptoms. What was the second part again, Barb?
I think it was, just if there was any presentation that was different, that maybe they are having more maybe diarrhea first instead of a fever or anything like that. But I would think maybe it's too soon to sort of get those sort of trends. But I was just wondering if you'd noticed anything.
Yeah. Our pediatric population is about 1% of the population, but they're a very important part of population. And we do have children's units and children served throughout our 5-state region. And so we have a pediatric nephrologist on our board and on our medical review committee, and we are monitoring them because I think of the populations, they probably will have the most different symptoms. We're hearing it's more inflammatory disease, it's more diarrhea and vomiting. So we're still kind of monitoring that population separately from the adult population.
Thank you.
So, note in chat, we have a question from Janelle Shear from Superior Health in Minnesota. Janelle?
Hi, Diane. Thank you so much for sharing about the Midwest Kidney Network and the work that you're doing with dialysis providers. Looking at that table that showed the numbers and percentages of folks with COVID positive, one before that. Yeah, that one. So I see the variance. There's quite a bit of variance in compared to the public and just the numbers of the states. I'm wondering, do the numbers, do you think they're because of location of where the patients are, such as does Michigan a lot more in long-term care and those are the people, or does it have more with preventing the spread of COVID in those actual dialysis or renal places?
You guys are asking really good questions. I think the variation, I just saw a presentation yesterday, and why would, particularly for example, African Americans, why would they be more at risk? Why would urban areas be more at risk? Why was it that New York, New Jersey, and Michigan were the top 3 in the country, not only for the ESRD population, but for the general population? And there were a number of hypotheses, including density, public transportation usage, social determinants of care, poverty, lack of health insurance. We believe that it's not being in a dialysis unit that puts you at a higher risk, because we can't demonstrate that the increase was related to that. It seems more community transmission. So we're working with local health departments to do tracing to help people to early identify that. And it might not have been in the dialysis unit, that might have been a family that had COVID, but actually there was only one case in the whole unit. If you look down to South Dakota, you'll see that they have an unusual one, and we know that they have a meat packing plant there that has met with national news, and that they had 800 cases just in tracing of that one population in that one community, the same number that had all of ESRD cases in all of Michigan. So I think sometimes it's the community that you serve, the work that they're doing, their community transmission. So I think we are going to find that this was a disease that was particularly harsher for poorer people, people of color, and people that were reliant on public transportation, and people that lived in multi-generational homes in very dense housing. Those were some of the ones that come to mind, Janelle, that I can think of.
One other question, are there any unique precautions that staff in dialysis centers use that other health, in addition to what other health care settings are using, or is it the same as everybody else?
The standard that we're hearing is that people that are treating non-COVID patients, they are doing the routine precautions with face shield, mask, gowns, gloves. And that has been a long-held universal precautions practice. We're finding that there's any aerosolization, if there's any risk, then people would, if you're treating COVID patients, you'd probably add an N95, but to treat dialysis patients on a routine basis, N95s is not the standard of care. I haven't talked much about transplant recipients, but their main concern was access to their medications. And so transplant patients, home patients, and dialysis patients to do other than their in-center dialysis, they're using a lot more telemedicine so that those so you're not spending the PPE was really a rare commodity and just lowering the risk. But I would say for other than everyone just being very, very careful, some large hit areas were making their own disinfectants, their own sanitizers when those weren't available. But I would say that the standard provision of dialysis would not be using an N95.
Thank you, Diane. I don't see any other questions in the chat, and I would like to open it up again if you have any questions for Diane, or if you have any general questions or comments or sharing for each other on any other aspect of managing this pandemic. Diane, while people are becoming less shy, I'll just ask you a final question from my perspective. Is there any advice you would give to this audience on how to manage this cohort of their patients that you haven't already mentioned?
Oh boy, that's a really challenge. I guess if I had to pick one thing, I would say in life it's dangerous to be siloed. And we all care about transitions, and you might be the best institution, but sooner or later your patient's going to transfer in between institutions. So you are going to go from a long-term care setting to a hospital to a dialysis unit. And it's incumbent on all of us to have tools in place to make those transitions safe, to not transport a COVID positive patient in a van with COVID negative patients and then send them to a non-COVID dialysis unit. So we have seen those mistakes. And so it's absolutely paramount to work with one another. And for people who don't have tools of checklists, of quick cheat sheets that travel with the patients during those transitions, we really want to improve, whether it's through electronic medical records, health information exchange systems, or patient clipboards that travel with the patient to and from. We have to have good communication so that the receiver, the sender and the receiver feel a really good handover, that patient gets the best care on all transitions of care. That would be my one I think I'd pick. If I had more time to think, I'll think of 12 more, but that's one that comes to mind. And I know everyone on this phone call cares about care transitions, so it's really wonderful to work with people like you that share that same aspiration.
Thank you for that, Diane. A comment in the chat from Lisa is transportation is an issue for sick COVID patients. And I think we all agree with that.
We have.
Any last questions or comments from you, Diane, or comments from anybody on the call?
I did see one other question in the chat just about expanding on those transportation resources and where health systems can go to help support patients. I know you mentioned it in one of your slides here about these transportation tips.
Yes, we did find that some private companies did close initially. They did not have the resources. So we were scrambling to find who is willing to transport COVID positive patients, and that they have systems that the drivers are educated, that the patients and the driver are separated, that they clean the vehicle between patients. And we found in each state there were systems that were willing to do that. We did not want to tax the ambulance system, and that's not always guaranteed that the provider that did that would be, we were trying to advocate for that, but it's not guaranteeing that ambulance would be paid for, and there might not have been the capacity too. So we were in those tip sheets, we have the links and the phone numbers of who you can call in your state that would transport a non-COVID patient, a COVID patient, and people for a variety of reasons getting to different appointments. So that's just a quick, I know transportation was a big issue, and we were really pleased that some companies retooled themselves very quickly to, they were formerly a van service that would do 7 and 10, but they quickly then converted and found smaller vehicles that would just do one-to-one transport. And we had to do dialysis schedules so that people could still get to their dialysis on time with that different transportation arrangements. Family members and other people also stepped up, so we're really grateful for community response on transportation.
Great, and those tips can be found on your website, is that correct?
Yes.
Thank you for catching that question. I missed that, Elena. This is kind of the last call for questions for Diane. We're trying something a little bit different today. We asked a couple weeks ago if you as an audience would be interested in sharing within your own state. Excuse me. And so as we're wrapping up this call, we have an opportunity to join those in your own state to share anything or network. And I guess I will ask Elena to explain that process. This is the first time we're trying it, but basically it entails jumping out of this Zoom and link and clicking on the new link so that you get in with your own state cohort. Before you do that, I just want to ask, are there any last questions for Diane?
Well, I guess I just have one more before we break off. Diane, I see also mental health issues. Have you seen anything, again, specific to this population that might be different than what we've been hearing about in the general population regarding, being overly concerned about what's going to happen to me, or depression symptoms, or being isolated from family members that they usually have connection with? Anything in particular, and any interventions that people felt or saw were helpful, or resources in the community?
One patient grievance comes to mind that broke all of our hearts. When you're on dialysis, it usually is about 4 hours, and to mask for 4 hours is a long time, and one person just was not able to tolerate it and couldn't do it. So that person is upset. The dialysis staff are all upset because they feel the pressure to protect all the other patients in the unit, protect their staff. So masking is an industry standard now during the COVID season. So things started escalating and escalating. Everybody's stressed, the patient staff, the stress. The patient finally did lash out and struck and put their hand through a television screen. And so police had to be called. It was just a very sad situation when that happens day in the life, that's sad enough, but we just feel that it just was, to me, a real reflective thing that fuses are short, schedules are tight, lots of patients to serve. Everybody wants to keep good infection control. Deep cleaning and infection and hand washing takes extra time. So it just, to me, was one of those sentinel moments that really illustrated in another time, I think they could have calmed that patient down, staff would have calmed down, they would have found ways to help person in that, to de-escalate, to calm down a little bit, to move maybe to another space and get helping. We do have social workers in dialysis units, we do have trained. So that was just an example that I think not to minimize what you just said in your question, the loneliness, the isolation, the high stress. The person next to me might have it. Would I catch it for them? If I do catch it, am I going to live? Seeing patients who didn't make it. So in a dialysis unit, you're usually then see the same people. So if they're not there, what happened to them? So it's high stress for everybody. And I would say that that's not unique to the in-center population. But I would say transplant recipients are also have to watch their immunosuppression. They don't want to lose their graft kidney. Home dialysis patients might feel, are they getting the support that they need? And staff for transplant programs, we're in a turmoil. That's a whole nother talk. So I would say I want to continue to learn from all of you too, that I can see that many of you are developing things for isolation and depression and loneliness in the long-term care population, particularly those that are quarantined in nursing homes. So thanks, that's a hard question. I think we're all going to need to battle that for, I would say, at least the remainder of this year, if not longer.
Thanks for that, Diane. And thank you, Barb, for asking the question, because I think it was always in the back of our minds, but you articulated it in a way that I think was very, very helpful to all of us. And Diane, we thank you so much for presenting today. I think everybody got a lot out of your presentation, and we invite you to back on our weekly calls, because I'm sure that you will have something to contribute in going forward as well. So with that, I'll turn it over to Elena, and she can walk us through the chat, how to connect to your state-specific follow-up to fill out the hour. And again, thank you, Diane.